Good morning, everyone. It is 10 o'clock, so we're going to get started on our presentation today. Welcome to the Caregiver Toolbox, Practical Tools and Approaches for Caregivers. I am Christine Drasher. I am going to be your host today. I am from Emerald Crest Memory Care. Emerald Crest is sponsoring today's talk. We have 4 locations in the metro area: Burnsville, Minnetonka, Shakopee, and Victoria. We have been around for over 20 years, which is amazing. Time flies, and we offer a very unique approach to memory care within those communities. We have some really nice environments. They're houses. We have 12 to 15 residents per house, and every community or location has anywhere from 2 to 5 houses. And the environments were designed specifically for those with dementia. They're one-level houses that are very easy to navigate and are very home-like. So it's a great alternative to those who don't need the nursing home but do need 24-hour care. We work with occupational therapists, which you're going to meet one of our occupational therapists today, Jenny, who's our speaker. And we are very proud with our program because our program is very tailored to the residents' needs, with the OTs doing cognitive assessments and working with our nurses to really make sure we're meeting our residents where their function is at. Our houses are staged, so we have different levels of care, and the reason we do that is so that individuals can be with others around the same ability that they are, but we can also really focus on their ability and instead of their disability, and really have the activities and the programming and our approaches specifically to what those individuals can still do and have success to. We have a lot of great training for our employees, and they must go through that in order to be able to continue to work here at Emerald Crest, and we continue that ongoing annually with them as well. So there's our locations, just to go through them quickly. Again, it's Burnsville, Minnetonka, Shakopee, and Victoria. Liz Wendell is our admissions director. You see her picture there. She is the one to talk to in regards to information, setting up a tour. She'd be happy to show you around and also answer any other questions that you might have. So that is a little bit about Emerald Crest. We're going to actually go right into our presentation here, but before I do that and introduce our speaker, I want to do a quick poll of everybody who is on the presentation today. So if you don't mind clicking on reading this poll and submitting your response, I'd appreciate it. All right, I'm going to share the results there for you. So this will just help us and help Jenny as she's going through her talk here to have an understanding of who the audience is. So thank you for doing that. All right, so we're going to move on, and I'm going to introduce Jenny here for you. You can see she's right there on the screen. Jenny Lavoie is our director of our cognitive care program at Emerald Crest. She works out of our Shakopee location, and she's been here for, gosh, 18 years at Emerald Crest. So she has a lot of experience with working with all different levels of dementia, and also working with families and staff and nursing while caring for these individuals. You can read there, her role is very integrated into the team to really develop strategies and techniques to really fill those gaps that those individuals have and maximize the residents' abilities and level of function. So she works very closely with behavior management, staff training, and also the activities that we provide for our residents. So let's go ahead and get Jenny on here, and thank you for joining us. All right, Jenny, off to you.
Thank you, Christine, and good morning to everybody attending. Just looking at the poll, it did look like the majority of people that are on today are family members or caregivers of someone living with dementia. So I think this talk today will be very hopefully helpful because like Christine said, it's really a lot of practical tips that we'll be talking about to help you as you navigate your way through this journey with your loved one that has dementia. Kind of the main focus or the objectives that we'll be talking about today is first and foremost, really talking about the changes caused by dementia, having a clear understanding of the changes caused by dementia. And we're going to talk about specifically those changes that happen with communication of that individual and their participation in their daily cares and activity, how that changes as they progress through the disease. And like Christine had mentioned, behavior is another hot topic when it comes to dementia, how we help manage behaviors that we see. And then we'll also be talking within the presentation, becoming more familiar with approaches then. Once we kind of know what the changes are, what are common approaches that are used to provide care to individuals with dementia at each stage. So I always like to start a lot of these presentations with understanding dementia, wanting to make sure that everybody that is here at the presentation today has the same kind of understanding of dementia, the people that we're caring for. And so that usually is my first question. I'll ask, what is dementia? And usually the answer that I will commonly get and what comes to people's mind first and foremost is memory loss. Which is very, very true of dementia, of this disease. The general term, as you can see on the slide that I give, or the definition would be a group of symptoms that affects an individual's overall thinking skills. So when you talk about dementia, it is very much about memory loss, but what I think people forget or fail to understand that it also involves changes in many additional cognitive skills that contribute to the thinking or cognitive process. So it's not just memory loss, it's problem solving, it's decision making, it's their changes in communication. I mean, you could go on and on all day with the cognitive skills that we use in our everyday that are being affected when someone has dementia. But when someone is diagnosed with dementia, it usually begins with those subtle changes. It's not somebody gets dementia and right away they can't dress themselves, feed themselves, bathe themselves. It usually starts in those early stages, which it's those higher level skills that people start to notice. So a lot of these people are living in their own home a lot of times, and they start to have difficulties within their home, organizing their home, managing their finances, driving, all of those higher level skills that someone that's still living on their own would most likely be doing. And a lot of times it's not noticed right away by family members because if they're living in their own home, they may not be seeing mom or dad or whoever that loved one is on a regular basis. So a lot of these issues can kind of go unseen or unnoticed for a while. Oftentimes, like we talked about, that first symptom is memory loss, and the reason people notice that is because it's measurable. It's more notable than, say, having trouble with problem solving. When they start to not remember names, remember common birthdays, dates, anniversaries, that's when maybe family members begin to raise an eyebrow, wondering if there's further issues. And it's not until they progress more into their dementia that you start to see then the issues with the dressing, the bathing, the grooming, the everyday care tasks. This next slide that Christine flipped to, I call this, it says components of cognition, or I oftentimes call it the wheel of cognition. And this again is just explaining more about how it's much more than just memory loss when someone is diagnosed with dementia. As you can look at this wheel, look at all the different cognitive skills that are involved just in everyday tasks that we take for granted. Not only memory, but their orientation to time, place, their language, their communication changes, Their attention, as somebody progresses through the disease process, their attention span becomes less and less and less. Their inability to focus becomes an issue. When somebody's in the late stage, their focus is maybe 5 minutes if you're lucky. Sequencing, a lot of times they start to, as they get more into the middle stages, they don't know what the first step is to something, the second step, third step, they can't sequence. So you see everything on here: object recognition, reasoning, problem solving, frustration tolerance. When somebody has dementia, these multiple skills or difficulties are going on all at the same time, and it can make it very difficult for them to function. This is just a nice slide to show people. I think it's a real eye-opener because it actually gives you a visual of the brain and what's going on when somebody is diagnosed with dementia, or specifically Alzheimer's. You can see, as you're looking at your screen, the brain on the left side is considered somebody with normal cognitive functioning, no diagnosis of dementia. And you can see how that brain is much larger. It's white, which is white, healthy matter, healthy brain cell functioning. And then you look at the brain on your right side of your screen and see how much smaller it is. You can just see the atrophy going on. It's almost like if you've ever broken a bone and you've had a cast on, and then they take the cast off and that limb or that body part is shrunken. That's what's happening to the brain when they have dementia. And if you look at the brain, you can see the gaps in the brain cells or the brain matter. Those big blackened areas are basically where cell death has occurred because of the dementia. And so again, as the brain is being affected by the dementia, the different parts of the brain, that's when you start to see the different issues, you know, whether it's attacked the communication center or the decision-making center of the brain. As that person progresses, it's going to, in the end, affect the whole brain and all cognitive skills. So in talking about dementia, once we know that somebody has actually been formally diagnosed with dementia, where the care team or the healthcare community goes to next is, okay, what stage are they in now? We know they have dementia, but what we really need to know now is, where are they? And when we look at stages, the easiest way to define the stages is using the terms early, middle, and late stage dementia. And this is going to be very important in order to consider appropriate care, appropriate approaches, and appropriate services. It's going to be very different for somebody in the early stage, what you would recommend and what kind of approaches you would use versus somebody in the late stage. So now that we have talked a little bit about what is dementia, what does it look like, let's talk about this caregiving journey that it sounds like many of you that are attending the presentation are on. So along the way in a caregiving partnership, I always kind of compare it to a road trip. So we've all been on road trips, I'm assuming, and we know that when you talk about a road trip, you usually have your driver and you usually have your navigator. And so in that caregiving partnership, when you're talking about caregiver and somebody with dementia, it's generally the individual with dementia that is the driver. And people get that confused. They kind of think, well, it's the caregiver that's the driver. And that's not true. It's the person with dementia that drives the care. You have to know where that person is in their dementia, what stage they're in, so that you as the caregiver know how to navigate or how to assist them. So think about it as you're their GPS, if you think of a road trip example. So without your guidance, without your navigation, they will potentially have the potential to become lost or fail in their functioning. So as we talk about caregiving, as we talk about dementia, I brought it up first slide with the objectives. We know that when somebody has dementia, their communication is going to greatly change. So when we talk about communication and dementia, we know that it changes, and we refer to the changes in communication that we see as aphasia. And many of you are probably familiar with that term. When we talk aphasia, there's two different types of aphasia. There's expressive and there's receptive aphasia. So that receptive aphasia, you start to see that more early on. Receptive is the inability for that person to process. They're slow in their processing. They're slow in their understanding. A lot of people in the early stages of dementia, expressively, they're still very good. They're still very good with their verbal skills. You may not notice anything's wrong right away by talking to somebody in the earlier stages, but even in the early stage, we start to see some of that receptive aphasia where you might say something to them or give them a directive and they kind of look at you blankly, and it's almost like you can see the wheels turning in their brain. They're trying to process and trying to figure out how to respond. That's that receptive aphasia. Now, as the dementia progresses, then you start to see more of the expressive aphasia. And that's probably what most people are more familiar with, where they start to have more difficulty with their verbal skills. So having more trouble coming up with the right words, they have more word finding difficulty. They may start to repeat their stories, their questions more often. That's more of that expressive aphasia. When that person is into the late stages, it's going to be affecting, they're going to have both the receptive and the expressive aphasia going on. So we know with communication, what they say changes, how they say things changes, how they hear and understand things changes. And if you look at this slide, I have it divided out into early, middle, and late stage. So communication in early stage, like I said, it's more just that of receptive aphasia. As they go into the middle stages, it's more difficulty, not only understanding, but then more of that expressive aphasia starts to come in, expressing their thoughts and ideas. And by the time you get to the late stage, like I said, it's everything. It's receptive, it's expressive. You're really relying more on non-verbal communication at that point. Another term that I think is important for us to understand when we talk about dementia and communication is apraxia. And a lot of people haven't heard of this term before. It's a term that's often very common, something that you commonly see in the late stage of dementia in particular. And it's when the brain does not consistently communicate with the body. So performance of activities is variable. So what is happening with apraxia? And if you do care for somebody with dementia and they're in the later stages, you've probably run into this quite a bit. The example I often use is with somebody, you're trying to get them to sit down on the toilet and you're giving them the directive, Bob, please sit on the toilet. And they're just standing there. It's almost like they're frozen. And I see caregivers that I work with battle with this all the time. And you see them really get frustrated because they think that the person is resisting them. And it's not that they're resisting them. With apraxia, what's happening is they're hearing the term or they're hearing the directive, Bob, sit on the toilet. But because of the signals being interrupted that's going on in the brain, they can't get that directive of Bob, sit on the toilet. They can't get that from their brain, and the brain can't tell the body what to do. The brain isn't able to guide the muscles, the joints, the lungs, everything. They're not able to guide, say, the hand to reach back or to know to pull the pants down or to bend at the hips and knees to sit down. And so as a caregiver, it can get very frustrating because here you are trying to give them a directive and you can't get them to perform. You can't get them to sit. And a lot of times, like I said, it becomes more of a needing to use nonverbals. You might have to give them more touch cues, tactile cues. You might have to guide their arms to the rails on the side of the toilet to help guide them to that sitting position. So it's something that can be quite challenging, especially in the late stages. Now, signs that an individual does not understand, and many of you probably or may have run into this with your loved one before. If they're not understanding, some of the common things that you're going to see is they may repeatedly ask what, or I don't know, or you're sitting there helping them dress, and even though the clothes are right in front of them, laid out, they're sitting there asking you, what do you want me to do? They don't know what to do next. If they're not understanding something, they may simply walk away. They may get frustrated, just say, pretty much enough is enough, and walk away. They may become verbally or physically agitated. And I always tell caregivers, if you get to this point, you need to just stop whatever you're doing, whatever communication technique or approach that you're using is obviously not working, and it's only further agitated them. And you don't want them physically getting to the point where they're hitting out or whatever. So you need to stop, maybe take a breather and figure out a new approach to try. If they're not understanding, they may even just cover their ears or their eyes or put their head down. I always think of my 2-year-old toddler at home, and not that I'm comparing our residents with dementia to children, but the way that they interpret or understand their world or their surroundings cognitively is very similar to, say, a young child or a toddler age child. And I think about my own kid. If he's not understanding, if he's just overstimulated, he's had enough, he'll just pretty much shut me out, whether it's covering his ears, eyes, putting his head down, or walking away. And I see that with our residents too when they're not understanding. So dementia communication techniques, I think one of the biggest and most important things for caregivers to realize is that individuals with dementia will focus less on the content of what you say and more on how you say it. So like it says on the slide, 90% of what you say isn't what's coming out of your mouth. It's all your nonverbals. And just because they have dementia does not mean they don't pick up on that. So if you're not using adequate eye contact, they're going to pick up on that. A lot of times you have to get at their level, especially in the late stages. When they start to progress into those later stages, even their ability to focus, to make eye contact changes, their gait starts to become more kind of a shuffled gait, a lot of times head down. And a lot of times just to communicate or to make any kind of connection with somebody in the late stage, I often find myself having to get right in front of them, sometimes even kneeling down in front of them and trying to really make that eye contact to be able to communicate and to be able to be successful in interacting with them. You may have to repeat statements when necessary, and it's not something you want to sit and repeat all day, every day, but you may have to repeat a couple times before it finally clicks with them and the communication, they understand the communication. And I have down here, know when to reapproach or redirect. If somebody is continually asking, when are my parents getting here? Or I need to go home. I need to go pick up my kids. If they're continually focused on something like that, you definitely want to acknowledge their fears and their anxieties. But at the same time, you don't want to keep focusing on it, because then it could even lead to even more anxiety, agitation. It's knowing, okay, when's the right time to maybe try to change the subject, move them on from whatever's causing them anxiety. And a lot of times I find myself doing that, changing the subject, talking about something that I know brings them happiness, or even trying to redirect them to some different activity so that they kind of forget about what they're focusing on. You need to speak slowly, stay calm, which a lot of this is kind of common sense. Don't argue or correct or question. Don't try to convince or reorientate them. And then a lot of times I see family members do this. They think, well, they're talking about dad who's been gone for 10 plus years, talking about him being alive. And family members a lot of times think, well, I just need to remind him that they passed away, so many years ago. And that oftentimes can be pretty detrimental to somebody that has dementia, because it's like they're hearing or learning of that information for the first time every time you remind them. So you don't try to reorient to them. It's, again, changing the subject or saying, yeah, dad will be here in a little bit. Or what do you remember about dad? A lot of times I will do that. I'll ask them to tell me about your mom or dad. And that gets them talking a lot of times in a positive light. Or if they're saying something that is not accurate, don't try to argue with them that it's not. Just go with it. It's like that you probably have heard, you have to kind of live in their reality. And always, of course, be respectful when communicating. Now that we've talked about communication, the next big area that I think is important to talk about when it comes to caregiving is how we deliver the everyday cares, dressing, bathing, grooming, all of that, because how that looks, it's going to be very different depending on where they're at, again, what stage of dementia they're at. But when we talk about care delivery essentials, regardless of what stage of dementia they're in, there can and should be a method to it. So what I mean by that is we should be using generally the same approaches. And I tell this to the caregivers I work with at Emerald Crest, whether you're on the day shift or evening shift or overnight shift, the approaches that we teach them, we expect to be followed the same, whether it's day, evening, or overnight. You want that consistency. It should not be a hit or miss type of method. It should be predictable and reliable. And like I said, it shouldn't vary from day to day or from caregiver to caregiver. So what we teach them at Emerald Crest is the same kind of throughout each shift, and the same for the different stages. So when we talk about caregiving, the role of the caregiver in delivery of care is really about compensating for the physical skills that are impaired or missing, but really, I think even equally or more importantly, is compensating for the cognitive skills that are impaired or missing. So how I look at caregiving, it's like we're filling in the missing pieces or the gaps for them. So if you think about, let's say you're on a bridge, you're going across the bridge and there's a big gap. How are you going to get from point A to point B? How are you going to get across that gap in the bridge? That's what we're doing for people that have dementia when we're delivering care. We're filling in that gap. And how we fill in those gaps is going to look very different, again, depending on what stage of dementia they're at. So for somebody in the beginning stages of the middle stage of dementia, if we're helping them dress, it might just be, hey, we have to make sure they have the right clothes for the day, set it out for them, cue them to the clothes. And after that, they're good to go. Versus if you're trying to fill in the gaps or help somebody that's in the later stages, you might have to do, it's not just setting out the clothes, you might have to actually physically assist them in dressing. So it's going to look different. However, though, instead of doing it all for them, we assist them to reach the desired goal. It's not that, we talk about talk to caregivers about, we don't want you just going in and doing it all for them just because they have memory loss. It's, again, like I said, figuring out where they're at and what is the best approach. You want them to be able to participate as much as they're able to functionally. Now, what I'm going to do with these next several slides is we're going to kind of break that down, the different stages, early, middle, and late stage. And we're going to talk about what the general approaches look like for basic cares. As you can see, I've got communication, meals, grooming, dressing, and bathing listed. So I'm going to talk about what are the general approaches that we use in those areas, depending on what stage. So I'm starting out here with early stage dementia. And when I think about early stage dementia, true early stage dementia, if someone's in early stage, they are generally, most of the time, still living to some capacity within out in the community. You don't generally see these people in facilities, memory care facilities like Emerald Crest. As you can see on the slide here, most of these people, they don't have a large problem with the basic cares. Again, it's more of those higher level skills that I talked about in one of those first slides, the dressing, the finance, or the driving, the finances, medication, all of those higher level everyday skills. When it comes to communication, meals, grooming, dressing, and bathing at the early stage, it's a lot of just verbal reminders to start. You might just say, hey, it's 8 o'clock, time to get ready for the day. And then from that point, they're able to go to their closet. They're still able to make decisions as far as what to pull out to wear. They are able to usually just go ahead and groom independently after they're maybe just reminded, hey, let's get up for breakfast. Why don't you go wash up? Bathing, set up in supervision. So, again, able to pretty much be pretty thorough with bathing. They just have somebody standing by for safety because falls risk can be still an issue in the elderly. So that's really what you're going to see with early stage dementia. It's a lot of just verbal reminders. As we progress through the stages now, and you're going to see as I'm talking about the different stages, you're going to see, like, as I get into the middle and late stage, I'm actually going to divide it out, because somebody in the early middle stage can look quite different from somebody in the late stage. And so as I have here, early middle stage dementia. So with this, what becomes an issue with the people in the early middle stage is the quality in their cares. Can they physically put on a shirt? Can they physically put on pants? Yeah, most of the time these people can. But what you'll start to see with people at this stage is the quality starts to go downhill. The completion starts to go downhill. These are the people that are commonly going to wear the same outfit for a week straight and not know any different. These are the people, if you're not in there to at least set them up and remind them to get going with the day, they're going to not remember to brush teeth or use toothpaste. Or these are the people that are going to say, I don't need help with a shower. I take a shower by myself every day. And you know they haven't taken a shower in days or sometimes even weeks. So it's often what works best is setup and supervision, where we get them started. We help actually physically help them pick an appropriate outfit, clean outfit. We help make sure that they have the appropriate grooming supplies. And then we give them that cue to start. And you may be able to leave and check back with them, but you always want to check back and make sure that they have completed it, they haven't missed any steps. So that setup and supervision technique that I just talked about, why do we use it? Well, it gives them a verbal cue to get started. Otherwise, these are people that may lay in bed all day if they didn't have that cue to start. It helps make sure all needed supplies are available and used and not missed. If possible, we always say lay out the items in the order. If I just take a pile of clothes and put it on the end of these folks' bed, they may just go and pull whatever they see first. So they may pull the shirt on without forgetting to put their bra on, or put pants on without remembering to put clean underwear on. So a lot of times what I'll do for these people is I'll actually lay out the clothes in the order in which they would put them on. It provides supervision to ensure quality and completion. The care partner, like I said, they may be able to leave and, check on somebody else or tidy up the room, but you always want to make sure you check back, because if they do run into a problem, they might not consistently know what to do. Now, like I said, I'm kind of going through the middle stage, but I'm breaking it down. So with middle stage, I talked about early middle. Now we're kind of into middle. And with these people, it starts to change, where you can't just set them up and say, hey, go ahead and get started. They actually need not only setup of grooming supplies, dressing supplies, bathing supplies, but they actually need somebody to stay with them and give them step-by-step cues. A lot of these people still are able to, again, physically put on clothes, physically groom, physically wash themselves. But if you don't have somebody there with them the whole time, they might start to have difficulty knowing, okay, I put my pants on, what do I do now? So they kind of need that person cueing them. Okay, there's your shirt. Why don't you go ahead with that next? And you have somebody kind of doing more, I would say, the cognitive work, the cognitive thinking, by giving those step-by-step directions. So again, that step-by-step technique that you often see recommended at this more middle stage is you're staying with the person through the duration of care. You're guiding the individual through each step of the care so that they know the order. So this is that sequencing I was talking about when I pointed out that sequencing on that wheel of cognition. This is kind of that point in the dementia where they don't remember how to sequence. They don't know what comes first, second, third, fourth. That's why they need that step-by-step. Again, staying there, you're ensuring that they complete all the parts and with quality. And you're monitoring the speed of care. I've been on many assessments where the person is still living in their own home, and I'll oftentimes hear the family members say, literally, they'll say, Dad sits in his room for 2 hours. It takes him 2 hours in the morning to get dressed, and they're just baffled by it taking him that long. Well, why do you think it's taking him that long? If somebody's not in there actually cueing him through the steps, just think of the struggles. Just think how long it's going to take that individual to figure out how to get through just even dressing. So by having somebody there with them the whole time, you really can keep them, moving along with the task. So as we go, we've talked about early, middle, we've talked about middle stage dementia. Now we're kind of talking about late middle stage. Again, these people look very different from the start of one stage to the end of one stage, even though it's all middle stage. But for the late middle stage, it's more now one step at a time direction. So it's not just staying there with them and saying, okay, there's your shirt, go put it on. There's your pants, put it on. They're starting to kind of struggle with consistently knowing what the shirt is, how to use this utensil for eating. So we go as far as not only just giving them the step-by-step direction, but recommending that you actually hand the item that you're trying to help them with. So if you're helping them dress, you're handing the shirt and saying, here's your shirt, please put it on. Here's your pants, please put it on. You're actually, with mealtime, if you just give these people one big plate of food with everything on it at the same time, they don't even know where to begin. They get very overwhelmed by that. So a lot of times we can even break down their meals and just give them a smaller plate, with just say they start with the chicken, they eat the chicken, then you bring out the next plate with just the vegetables. So you can break it down so they can better focus and not get so overwhelmed. So that late middle stage, you're going to see we often recommend you're handing the item and then you're providing the step-by-step direction as far as what to do. So, I've just talked about a lot of this one item at a time technique. It's used to focus their attention to each step of the care. It helps them focus attention to the objects because they may start to have more trouble using the objects, guide the resident through the care. And again, you can kind of help speed somebody up or slow somebody down by just doing one thing at a time with them. So now what we're going to do is we're moving into late stage. And even in late stage, I kind of break it down for you. So in early late stage dementia, we're now moving to, this is a person who is really starting to struggle with how to use objects. These are people who I often see, they're sitting at a meal and they start to use a fork to comb their hair. They don't know how to use utensils correctly anymore. They don't maybe know how to use a toothbrush or a comb, any of that. So it doesn't necessarily work as well just to stay there and cue them verbally as far as what to do. At this early late stage of dementia, you have to start by actually physically providing more hands-on assist. So like for dressing, it's often called staff starts, resident finishes, where I might start the shirt for them and then let them pull it over their head, or I might physically start the pants for them and then let them stand and pull it up. Or I might do a lot of times what's called hand over hand assistance, where I place the toothbrush with the paste on the toothbrush in their hand, and then I physically take my hand and move their hand to their mouth and start the brushing motion. Same thing at mealtime. You might have to do some hand over hand assistance where you're actually taking the spoon with the food on the spoon to their mouth and actually helping them take the bites. And the reason why we do a lot of this is we're trying to get the wires to connect in the brain at this point. We're trying to kind of prime the pump. And the idea is if we start the motion for them, the idea is that hopefully the wires in the brain will eventually connect, and then they can continue we can kind of pull our hand away or pull away, and they can continue with the activity or the motion. So a lot of times you're going to see caregiver starts, individual finishes for basic cares when you're in that early, late stage of dementia. And again, this is just talking about why do we use that approach at this level. Again, it gives the individual time to understand the care, gives the time for the wires to connect. Like I said, this is the stage where you're often going to start seeing them misusing objects. So it's really trying to help them remember how to use those objects. And here's the big one. People start to think late stage dementia and they think, oh, they can't do anything for themselves anymore. I'll just do it all for them. And I oftentimes have to remind caregivers that these folks can still be functional to some extent. And our goal as a caregiver is we want to maintain that function as long as we possibly can. So the more you allow them to do whatever degree of activity they can, the longer we're going to be able to maintain their abilities. It's that whole thing that we've heard before. If you don't use it, you lose it. And that's huge when it comes to dementia care. The other thing too, and caregivers, I think, have a hard time understanding this, is they think it's just easier if they go in and just start doing it all for them. Then they can get done faster and they can get on to the next task. But what you often don't understand is that this is a person who is starting, they're not using their verbal skills. They often have to rely on nonverbals. And you have somebody that's coming in and then just starting to take their shirt off or their pants off with no explanation or trying to let them participate. Well, guess what? You're going to have somebody that's probably going to end up being more resistive at this stage if you just go and just do everything to them or for them. So by allowing them to do what they can, it does promote more cooperation and can make it easier on you as a caregiver. One technique that I always like to bring up when I'm starting to talk late stage of dementia is start at the feet and work up. And let me explain this a little bit. When you have somebody in the late stage of dementia, like I said, they're starting to not be able to use verbal skills as well. They're not able to use words or understand words as well. So you really are relying on the nonverbals. And so with that, if you have anybody that's resistive, people typically at the late stage are going to be more physically resistive. So if they're not understanding something and they're scared, oftentimes these are the people that potentially are going to hit out or strike out because, again, you got somebody coming at them, trying to do something to them, and they don't understand what's going on. They feel attacked. So a lot of times starting at the feet and working up with any type of care can work really well. And what we're doing is we're trying to prevent or decrease resistiveness, and we're limiting feelings of fear for this person. So the idea behind it is you're starting at the area of the body that's least intrusive. And then therefore, this hopefully gives the resident time to understand the care that you're trying to complete with them. So let's take showering for an example. If you go in and you just start washing their chest area, especially for a woman, or their private areas, and again, that person isn't necessarily understanding what's happening right away, you think you're going to get somebody that probably is very fearful and then therefore very resistive. So the idea is let's start at the feet. Let's just say, Bob, let's wash feet. And then you start to just gently wash their feet. You're at that least intrusive part of the body. And then you slowly kind of work your way up. You start to then gently wash the legs. And then as you work the way up to the body, to the more maybe private or intrusive areas of the body, the idea is that that by then they're starting to kind of connect the dots. The wires are connecting and they're understanding, oh, they're trying to help me wash or they're trying to help me dress. So a lot of times in our care plans, especially for late stage people, we often have for techniques to remind the caregivers, if you're washing, if you're dressing, start at the feet, then work your way up. So that's kind of your early late. Now I'm moving into more your late. And with late stage dementia, it really gets to the point where this is probably where a lot of times they are physically having to do pretty much everything for the person. So you'll see here communication, meals, grooming, dressing, bathing. a lot of times it's the caregiver starts, and you may just try to get them to hold maybe a toothbrush or hold a comb for them, or when you're mostly dressing them and they're just maybe helping by positioning the arm or the leg in a position so that you can get the clothes on. But you, for the most part, total assistance, you're physically having to do most of the cares for them. With meals, you'll see finger foods. At this stage, oftentimes they don't know how to use spoons, forks, utensils like that anymore. So a lot of times what we will try, instead of just going to just feeding them and taking away any type of ability, we try to give them finger foods, because a lot of times people, even at the late stage, they may not be able to use utensils, but they can pick up foods. So try to put things into sandwich form as much as possible, or give them things that are more pick up and eat. Again, trying to maintain function and abilities for as long as we can. So like I said, care partner completes cares is often very commonly used when it comes to late stage, and why we use it. They're losing, or they've lost the understanding of the whole process. So a lot of times we have to do it for them. At this point, they're not knowing how to use objects anymore. They're a lot of times not maybe communicating verbally anymore. It's, again, a lot of those nonverbals. And remember that apraxia I talked about? This would be that stage where you see a lot of this going on, where the brain just can't communicate that directive to the body to complete the movement or the function. So they're having trouble coordinating the movements because of that apraxia. And I always like to kind of just give a few tricks of the trade when we're talking about different care delivery. So with meal times, tricks of the trade, our biggest thing is always simplify the setup. So if we can go from a regular plate to, like I said, that one item at a time, that can really help a lot of people. We also use small portions, and we use what's called divided plates. And if you're not familiar with that, that's those plates that have like the 3 sections. And so you can really kind of simplify, present it as smaller portions for people that get overwhelmed with a lot of food. So you just give a small ice cream scoop size of, chicken maybe in one section, vegetables in the other, potato in the other, and a lot of times just reducing or simplifying how it looks on the plate can really help with somebody eating. We always say sweeten it up. I always say, if all else fails, even in the late stages, people tend to still love their sweets, right? And so a lot of times, we might put, make things with more gravies and that type of thing, or, jelly, jams on things, chocolate. We use a lot of chocolate on our desserts. A lot of sweetening up of things can help that person with their appetite and eating more. And then, like I said, finger foods, I kind of explained why we use that a lot of times. Dressing tricks of the trade. I always tell family members, bring in loose fitting clothing, easy on, easy off. There's nothing worse than you're dealing with somebody that's really apraxic, they're rigid, they can't move, they're not understanding directives, and you're trying to get these jeans on that you have to zip up and button, and they're super tight. It's the worst feeling in the world as a caregiver, and a lot of times can add to extra agitation for that resident. So anything, I always say, bring in more of the elastic waistband type of pants, the bigger fitting, loose fitting shirts. Anything that can like button down the front is always better than over the head, because trying to pull something over the head is really hard a lot of times, especially as they get into the later stages, to move their arms to do that. And it gets very frightening when you're trying to pull things over their head. Eliminating unnecessary steps. So, I know a lot of these men in particular, especially if they were businessmen, they always wore the white undershirts, under the dress shirt. Well, I tell you, as you get into the later stages of this disease, that's just another step you have to add, another thing that has to go over their head, and it can make it very difficult. So I talk with families a lot about, let's simplify it. If you're okay with it, let's just get rid of the undershirt. Let's just do the basic shirt. Even bras. And I know that can be a dignity issue for women, but I'll a lot of times, if it gets to that point, recommend whether it's just like a camisole instead that goes underneath, or if it's to the point where they don't really need the bra anymore, I ask family, is it okay if we go without? Because again, trying to get those bras on can be very difficult when you have somebody that's not understanding the process. They're having trouble moving. It can be very, very difficult and agitating. Again, trying not to have to do multiple layers is a lot simpler. Multiples of the same outfit. A lot of times we run into, and this can be in the middle stages too, people that are kind of focused on one particular outfit and they want to keep wearing that same outfit over and over and over and over without it being washed. And so I've recommended to families, if you can find the outfit, buy multiple sets of it. That way we can sneak it out of the room. They have no idea. And then the next day they have the same outfit, 7 other of the same outfit that they can grab and wear again. That's often worked successfully before. And adaptive clothing. I don't know how many of you have experience with adaptive clothing, but again, you're going to see this a lot with people in the late stage as they have a hard time, more difficult time understanding the process and understanding or difficulty moving. Regular clothes start to become a real challenge to get on and off. So especially like in our late stage house at Emerald Crest, a lot of our people are on adaptive clothing and you wouldn't even know that it was different clothing. It's a lot of clothing that like buttons down the back or pants that zip or button up the side. And we actually use at Emerald Crest, we use a resource called Buck, B-U-C-K, and Buck, B-U-C-K. And it's strictly a company that does adaptive clothing for seniors or people with special needs. And they've really come a long way. I tell families, you look at their product online or in their catalog, and it's clothing that looks like any other clothing you'd buy in any regular store. They have prints on it. They have a variety of colors. They make nice products, but again, it's clothing that can button up the back, zip up the side. They have adaptive shoes. They even have nightgowns that can button in the back, things to make it easier, or clothes to make it easier as far as dressing, getting on and off. When we talk about bathing, I would say of any of the cares that you talk about with dementia, bathing is always the most challenging. You got to think bathing, it's multiple steps. It's a long process and it's a very invasive process, especially for those with dementia that aren't understanding. So time of day, the bath or shower is offered. I always tell caregivers is so important. And we try to do, I know at Emerald Crest, we try to do a really good job of, before the person moves in, really interviewing the family and really learning about what was their routine, what was their usual bathing routine, care routine, so that we can try to mimic it as much as possible when they're at the facility. But time of day is so important. I tell caregivers, if you're trying to get somebody into the shower at 7 in the morning on a cold January day, and their whole life, all they have ever done is taken their shower at 10 o'clock at night before they go to bed, you're probably not going to have a lot of luck. It doesn't matter that they have dementia now. It was a routine that they had their whole life, and now you're kind of disrupting that. So that's so important. We always say, come with me. You never want to tell somebody with dementia, hey, we got to take a shower now. It's time to wash. You'll probably lose them right there unless they just absolutely love their showers. But come with me. I need to show you something. I'm going to help you. That's a big thing, is come with me. Bathing history. A lot of these folks that we work with, they came from a generation where they were lucky if they took a shower once a week, once a month, whereas today we're so used to taking showers every single day, sometimes multiple times a day. Well, that's not necessarily what they were used to. So we really have to consider that. Always crank up the heat as much as you can. It's like I said, it's an invasive, it's cold. They're very vulnerable when they have to shower. So making it as warm as possible oftentimes can help. We have heating lights or warming lights in our bathrooms. Using a bath bench, I always tell caregivers, I don't care how mobile the person is or if they walk on their own, I always encourage the person. We have nice rolling shower chairs, or the bath benches work nice to sit down to shower for that safety reason. Washing the hair last, that's a big one. I've had caregivers that are assisting with a shower, and they go right to the washing of the hair. And then that poor person has a wet head, they have soap in their eyes, and then they wonder why they're getting irritated because they now want to finish by washing the rest of the body. So I always encourage people, save that till the very end. And then you might have to quickly get through that because some people don't do well with the water on the head and the washing of the hair. I always try to make the whole process as comfortable as possible. So kind of talking it up as, oh, you're going to get pampered today. This is your day at the spa, anything like that to kind of put a positive light or spin on it. Water pressure is huge, especially as the person progresses through their dementia. Their sensory changes, and they don't always do as well with that water pressure on their skin or on their body. So you really got to watch that. And like I said, temperature, heating the room. I've even warmed the towels in the dryer before with some people that have difficulty that do better with just ready to go towels. Grooming hygiene tricks of the trade, grooming boxes. I don't know if any of you have ever considered that whole concept, but I know at Emerald Crest, we use them. And the reason we use them is, again, to simplify the person's environment. I have walked into bathrooms, resident bathrooms before, where you can't even see the countertops because family has brought in everything under the sun. You've got, 4 or 5 toothbrushes, 4 or 5 bottles of shampoo or lotion, and the person is having trouble making decisions as it is. And then they look at this cluttered sink and they don't even know where to begin. So we have in place what are called grooming boxes, where each person has a shoebox size plastic bin, and it has their name on it, and it just has the basics. It has a toothbrush, it has their toothpaste, it has their comb, their toothbrush holder, the lotion, deodorant, just the basics. And it's just brought out and used when they're helping them in the morning with cares. And then it's taken and it's kept in our laundry rooms. It's kept out of sight, out of mind, so they don't rummage through it. And then it's brought back and it's used when we help them with the evening cares. And then it's stored again in the laundry room. It's out of sight, out of mind. And that really helps to simplify and keep everything simple and understandable for them. I say remove mirrors, and sometimes we run into this again when somebody is in the late stage of dementia, where they'll be in the bathroom and they'll see their reflection in the mirror, and they don't recognize that it's themselves. I had a gentleman once that I was helping with the showering and grooming process, and we were actually in the main bathroom, and I was putting some of the laundry away, and he was in front of the mirror standing brushing his teeth, and all of a sudden he said, quick, come here, quick. And I immediately turned around thinking something terrible had happened, and I look and he's staring at his reflection in the mirror, and I said, what is it, Bob? And he said, that's my dad. And so he was looking at himself, not recognizing that it was him. He was probably thinking that he was still maybe a young adult or child, and looking at this elderly man that I'm sure looked very much like his father. And he was thinking it was dad, not recognizing it was him. Now, in this particular situation, it didn't seem to agitate him. I just said, your father's a very handsome looking man. And then I just kind of changed the subject and we went back to brushing his teeth. And it didn't seem to bother him. But I've had some people where when they see reflections in the mirror, they get very, very paranoid. They get very, very anxious. And we've actually had to remove the mirror to decrease some of that anxiety. Like I said, simplifying steps, always simplify. Incontinence, toileting, tricks of the trade. If you're having trouble in that area, sometimes signs on the bathroom door can work. I will say, though, the person has to be at a level where they still maybe understand verbal directives or they understand symbols. If they're into the late stages or, that type of thing, more than likely signs on the bathroom door to direct them to the bathroom is not going to help. So you really have to consider the stage that they're at. Colored toilet seat, a lot of times this can help, especially for men who still have that ability to stand and urinate. if they're having a trouble focusing or seeing that toilet, if you have that color contrast, that can help sometimes. Raised toilet seat. Now, this is really helpful, again, when I was talking about that apraxia and they're having trouble sitting or standing. If they have a really low toilet and they have to go low to the ground or stand from a really low position, that can be really hard and make it even more difficult. So if you have like some kind of toilet riser on there, then they don't have as far to stand up or sit down, and that can help. Hiding trash cans. Why do I say that? Well, again, for somebody in the late stage, oftentimes it's like, again, a small child. If they have to go, they're going to meet that need. And if they see trash cans or something that looks similar to a toilet, they will just urinate or defecate in that trash can or plant or whatever they see. So a lot of times, again, simplifying your environment and getting those type of visual cues out of the site. Having a toileting schedule, 2-hour toileting, you probably have heard that term often, is used to keep them consistently inviting them to use the toilet so that you can kind of prevent some of that incontinence with going too long without being invited to the toilet. Now, jumpsuits, we used to use that a lot more back in the day. Now it's kind of our last resort. They do have pieces of clothing that, like I said, it's a jumpsuit. It's a one-piece clothing that either like buttons all the way down the back or zips all the way down the back. And sometimes in really severe cases, we've maybe had to go to that where we use it because somebody is just urinating or defecating all over the house or all over the room. And we've tried other interventions and nothing is working, and we might have to go to that. But a lot of times we do try to stay away from that and try everything else first, because it can be seen as a restraint if they can't get out of that jumpsuit. But it is, like I said, a last resort option sometimes. As far as medication, tricks of the trade, medications can become difficult with dementia too. And oftentimes people refusing to take them because, one, they don't understand, or they might be paranoid that you're giving them something. So a lot of times I'll say, these are your vitamins. Your everyday vitamins. I take mine too. And a lot of times that'll work. Or your doctor asked me to give these to you. A lot of times, even in dementia, you hear the word doctor and they kind of respond to that authority figure. Sometimes we do have to hide it in food or drink or mix it in, or sometimes, especially in the late stage again, where they're having trouble now swallowing, trying to swallow those big pills becomes really, really challenging. And so sometimes the nurses have to get an order to crush the meds again, then it's mixed with yogurt or applesauce, and then they can take it. Now, a little bit about kind of their surroundings and their environment. Falls, as we know, becomes a real issue, especially as the person continues to progress into the middle and late stages. So again, simplify, 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 and that includes their environment. So decluttering, you don't want a lot of clutter, a lot of furniture. You don't want those throw rugs on the floor where they can trip and fall, floor mats, all of that. Get all of that out of there. Keep it very simple. A lot of times figuring out, working with maybe physical therapy as far as appropriate assistive devices. So would their safety increase? Would they benefit from some type of walker or even wheelchair? A lot of times we have to use alarms, whether it's bed alarms or chair alarms, to keep that person safe, to alert us. It's not going to necessarily prevent falls, but alert us that the person is up and we need to go and assist them. A lot of times I'm sure you've heard, or maybe you're experiencing it yourself, your loved one is trying to elope. They're trying to leave the house, their surroundings. So sometimes I've had family members have to put bells on all the doors so it alerts them when a door is opening. Or stop, again, this person would have to understand words and symbols, but even putting a stop sign or do not enter sign sometimes can stop people. Or just simply turning the lights out at night kind of cues them, oh, it's nighttime, it's time to go to bed, and sometimes can help. A lot of times with dementia, you have a lot of wandering, you have a lot of pacing. So what do you need to do? You need to try to use up that extra energy that they have. So I've had people that are on walk programs where we have caregivers have set times throughout the day where they just simply walk them around the house a couple times, try to use up that energy. And a lot of times that can help with decreasing that wandering that person is doing. So kind of like, again, in summary, the job of the care partner with the person is filling in those gaps depending on what stage of dementia they're at. It really does. It takes a lot of skill and practice from the caregiver. But a lot of times, if you're filling in the gaps the right way, it's not even obvious to the individual that you're helping that you are assisting them. They feel very purposeful. They feel very independent. It allows for successful completion of the activity. And I always say, the biggest thing is you want to stay calm. You want to stay as consistent, open, and creative as possible. And again, simplification is the name of the game. So now, as we get kind of towards the end of our presentation here, I just want to briefly talk about activity and how it looks different at the different stages of dementia. So with activity, we know when someone is living with dementia, they still identify with their lifetime roles and seek out meaningful and purposeful activity. And this is so true. I mean, think about yourself. Regardless of how old you are, you still have those hobbies, those interests, those roles that give you purpose, that make you feel good. I think about myself, when I'm 80 plus years old, and if I end up in a facility of some sort, I want to be able to still, I love wine tasting. I love going to wineries. So I want to be able to have my glass of wine at dinner at night. And we have residents now who they have a doctor's order and they get their wine at night. And it brings them just joy. Or golfing is important to me. I do a lot of golfing in my spare time. And I think about being in a facility or being at that older age where, maybe I can't get out and do a round of 18 holes, but maybe you can give me a putter and do a little putt right there in the living room. It's still kind of maintaining that role, that enjoyment that I've had from that activity. It's the same thing with our residents. So with activity planning as a caregiver, you really want to try to find that balance between enough stimulation and overstimulation. So you want to have enough of a structured day, but you also want to have times where they can get away, they can rest their mind and their body. You want purposeful activity versus just, filling the house with noise just to try to keep them busy. You want it to somewhat be meaningful for them. The goal in mind when creating stimulation is for the individual. It's not for the caregiver. I've had so many caregivers come to me and say, we've done this before. This is boring. Well, yeah, it's probably boring for you, but for somebody with dementia, it's like a new activity every day. So you got to keep that in mind as a caregiver, that for us, it's probably very, kind of boring and repetitive, but it's very different for that person living with dementia. Routine and structure provide feelings of control for that person, familiarity. It really helps to give them a sense of purpose and meaning to their everyday, consistency and dependability. It really provides safety and security. They're not left guessing, okay, what am I supposed to be doing now? They kind of go with that routine, and they kind of know that, at 9:30, we do some exercise. They might not know that it's exercise, but they know that something generally happens. And I oftentimes see our residents seeking it out. And it can give them a real sense of relief to have that regular routine and structure. So just briefly, I want to kind of, just like I did with CARES, I kind of want to break down activities for the different stages and kind of what successful activities look like at the different stages of dementia. So again, we're talking early stage. And again, these might be people that maybe have just entered a facility or maybe still out on their own a lot. You want to find, for people at this early stage, tasks with a clear purpose. So a lot of these people can still read and write. So even at this early stage, they may get enjoyment out of being part of a book club or a writing club. Open-ended, they can do a lot of things with open-ended conversation, because remember, again, at the early stage, their verbal skills are generally still mostly intact. So activities, a lot of socializing, maybe outings, like I said, different kind of groups, whether it's card playing group or a book club or whatever. lot of conversing, socializing. They can do still a lot of imagining, able to think more abstractly. And you'll see that with the different stages, I pointed out kind of attention span and number of tasks. And that's really important and key to somebody being successful with activities and not getting frustrated. So at the early stage, 45 minutes to an hour is kind of that goal you're looking for when you're doing an activity. Tasks that have 4 to 5 steps generally are doable for somebody at that stage. Now I'm going to kind of break that middle stage down a little bit like I did with CARES. So that early middle stage, you're talking more simple tasks with a clear ending. They really need to know kind of what, the start of the activity is and where the ending is and when they need to move on to something else. You still can have some talking at this early middle stage, but it's going to be more simplified where you're kind of as the caregiver directing or kind of leading the conversation with questions, with choices. But most of the time activities now are going to be more focused on doing. You're having them do something, whether it's a sing-along, whether it's a simple exercise game, whether it's a simple cooking group. It's more about hands-on with some of the talking. You'll see tasks no more than 4 steps and more now 30 to 45 minutes in length. Again, their attention is going to become less and less and less. The objects have to have meaning. It has to be concrete, clear ending to it. Now, as we go farther into the middle stage, this now becomes more about familiar tasks. It's not so much about talking anymore because having discussion groups at this stage can be very challenging. It's really about what can we engage them in. 2 to 3 steps, 20 to 30 minutes in length. And you need somebody there giving them step-by-step directions. So maybe it's folding towels. Maybe, like I said, it's doing a simple cooking group where you just have them read the recipe, or you have them, put the ingredients in or have them mix it. You're having them kind of do the simple parts. So again, it's very familiar tasks. Now, as we go into the late middle stage, it's really repetitive use of objects. So you're now talking tasks that are maybe 1 to 2 steps and repetitive. So maybe it's rolling yarn. Maybe somebody has enjoyed woodworking their whole life, and it's giving them a small piece of wood and a piece of wood to sand. Attention span maybe 15-20 minutes. So you're really going to have to start simplifying your groups and shortening them up or activities. They may, again, we're talking late middle or early late, they may begin to misuse the objects. So when you're doing any type of activity at this level, it has to have constant supervision. You can't just give them something and walk away, because you really have to watch. These are the people that are going to use the supplies inappropriately, or they might start to put like the small chips in their mouth. You got to be careful with that. That when we're when we're talking true late stage dementia, it's all about the senses. These are the people that, again, are most likely nonverbal. They're not using a lot of verbal communication. So you're really trying to focus in on the 5 senses: touch, taste, smell, feeling, hearing. So it might be playing some instruments, listening to music. That one picture on the lower left, that's like a fidget blanket or a fidget cup. I actually have a few of these for some of our people in our late stage house, and it's just things that they can hold and tinker with. It's got buttons on it. It's got ribbon on it. It's just having them tactily touch things and interact with things. Cooking groups are great, but it's mostly, you're not doing the cooking. You're basically presenting whether it's the birthday cake to them and having them be able to enjoy the cake, that type of thing. It's object focused, like I said. It's really just one step interactions. And again, most activity that you do at this level can't really be more than 5 to 10 minutes before they need to take a break. They just don't have that focus anymore. So the last thing I want to talk about today when we talk about caregiving and this journey of dementia is managing behaviors. We probably all know that when you're working with somebody with dementia, you're going to run across some type of behavior with that person. Some have, maybe minimal behaviors, and others it might be a little bit more intense, but we need to know how to kind of help manage those. And so with behaviors, we need to understand that when it comes to dementia, it's a method of communication of a need not being met. Again, if they're hot, if they're cold, if they're hungry, if they're thirsty, you and I can just verbally tell someone that. Folks with dementia, they can't always express that. So it a lot of times will come out as some type of behavior. And when we picture behaviors, we often think of behaviors and of that person very negatively. And we really, as a caregiver, need to start to think that when a person is displaying some type of behavior, it's not that the resident is knowingly resisting you as a caregiver or purposely trying to upset or hurt you. It's they're trying to tell you something and they have no other way to do it. So when we deal with behaviors at Emerald Crest, this is kind of the process that we follow. It's always trying to figure out, it's becoming that detective and trying to figure out what are they telling us. So we start to look at 4 main areas if we see a resident that is having a consistent behavior happening over and over and over. We look at medical need, personal need, caregiver need, and environmental need. And just real quickly to kind of focus on some of these main areas. Medical need, that's always where I go to first. So if I see, for example, maybe I have somebody where they're now reporting that they're refusing showers, and this person has never been resistant to showers before. So we got to start to think, okay, something has changed. What is it? So I always go to the medical need first, because that we can, with the help of the nurses, also tend to rule out that first. If there's some kind of underlying medical condition going on that's throwing them off, usually we can treat that before we then try to go and look at these other areas. So for example, I always use UTI as an example, urinary tract infection. If somebody has a urinary tract infection, if you've ever worked with somebody that has had one, that it completely throws that person off. That person probably doesn't even look like or seem like themselves anymore. Very confused, very agitated, very anxious. But if we can identify and then get them started on the antibiotics for a UTI, oftentimes you see those behaviors resolve because that person is functioning back at their baseline. And I'm not going to go through all of these listed here under medical, but if any of these areas are off, blood pressure, heart condition, diabetes, if they're in pain and they can't express it, if they have to go to the bathroom, they're hungry, thirsty, any of this can cause agitation, anxiety in somebody. So I always go to that first. We also have to look at a person's personal needs. So just knowing what stage of dementia they're in, that's so key in helping manage behaviors, because there are certain common behaviors that are associated with the different stages of dementia that if we see them, we shouldn't be surprised. It's then just knowing, okay, they're suspicious of others, they're refusing help with cares. How then can we intervene? How can we help decrease some of these behaviors that we're seeing? It's very common for people, especially at the middle stage, to repeat stories or questions. So how can we help decrease that? How can we redirect that? Wanting to go home, that's very common in the middle stages too. Hoarding, rummaging, wandering. You often can see that at various levels. Wandering in the middle stages is usually with a purpose. They're asking, I need to go to the bathroom, or I need to get home, or I need to go pick up my kids. Whereas wandering in the late stage, it's really just pacing, wandering. There is no direct purpose. Usually these are the people that, if they're still ambulatory, will just keep wandering and pacing until they tire out. So it's how do we use up that extra energy to help decrease the wandering. Urinating in inappropriate places, very, very common in the late stage. So what nonverbal cues do we need to really watch for to help decrease some of that? Even past memories, I will tell you, that's probably a lot of times what seems to be the source of people with behaviors when I see it. Something happened in their past that now is coming up and affecting their functioning, whether they went through a lot of abuse, a terrible divorce, maybe an abortion, had an accident, maybe they had a terrible loss of a parent, sibling, spouse. I could tell you story after story that I've dealt with people that have went through something in their past that has triggered behaviors. So it's, again, that social history is huge. Finding out from family if any of this stuff exists so that we can kind of help intervene. Caregiver need. When you have a consistent behavior going on, you always have to look at yourself as the caregiver. Are you using the right approach? Are you doing too much or too little for them and it's causing anxiety? What's your body language? Remember how I said earlier in the talk, it's more about your nonverbals than your verbal. So, what is your body language showing them? Or is it showing that you're open and caring for them, or that you're standoffish? If you're rushing them through cares, they're gonna get frustrated. Your tone of voice, they pick up on that. If you are coming in and you've had a rough day, you've had arguments with other family members, and now you're kind of showing that frustration and agitation with the person you're caring for that has dementia, they're going to pick up on that. They're going to become agitated. They're going to become angry. They're going to mimic your tone, your body language. You have to have forgiveness, ability to let go. The reason I say that is a lot of times, especially in the early middle stages of dementia, those people, I kind of equate them to teenagers. They have no filter. So if they're thinking you've gained some weight, or they don't like your outfit or your haircut, they're just going to say it. They don't know to kind of keep those thoughts to themselves like you or I would. And so they're just going to come out and say stuff. And sometimes it can come off as very hurtful. And I've had caregivers come to me and say that they were very, very hurt and they have a hard time dealing with it. And I have to kind of gently remind them that it's not the person. They're not trying to be mean. It's part of the disease process. Eye contact, using enough words or too many words, all of that in your approach can set a person off. And last but not least, environmental need. This is huge. What's going on in their immediate environment can really affect a person's functioning and level of behavior. So if there's not enough activity or no activity going on, no structure and no routine, we really can see a lot more behaviors, people pacing, wandering, asking to go home because they don't have anything to focus on. Visitors or no visitors, I will tell you at Emerald Crest, I see it all the time. It's been a little different with COVID the last year and a half or so because we haven't had as many visitors, but normally in a given year, especially around the holidays, when we have a lot of more family members coming in and out, I really start to see it throw them off. You start to see a lot more anxiety in their day, agitation, because they're just not used to all the activity, all the people coming in and out. Too much noise, not enough noise in the environment. TV, no TV. I could give a 8-hour talk on TV and how that can affect a person. And at Emerald Crest, that's why the TV that we use is very limited, because it can cause a lot of behaviors. If you think about what's on TV these days, especially these days, it's a lot of negative images and media that even you or I have maybe trouble kind of coping with. And we don't have dementia. Just think about somebody with dementia seeing all this stuff and hearing all this stuff. So we really try to limit the amount of TV that's used in their day-to-day because of those reasons. Like I said, daily schedule or no daily schedule is going to affect a person. Having a very cluttered environment or cluttered room is going to cause a person more anxiety or agitation, especially those that are paranoid and suspicious, that are, I think of the woman that's always hiding her purse. And then you have all that clutter and